Hello, everyone, and welcome to ICAP's Psychosocial module. I'm going to turn the microphone over to Mary Elsner for a brief introduction.
Hi, I'm Mary Elsner. I'm the Director of Obesity Prevention Initiatives at ICAP, and I'd like to welcome you to our first webinar in our series for MOC Quality Improvement Project, Improving Quality of Care for Prevention and Treatment of Childhood Obesity. I would just like to acknowledge our funders who have made this and all of the MLC project possible, and that is the Sprague Memorial Institute and the Illinois Department of Healthcare and Family Services. I'm particularly pleased by the work that's gone into this. So many people have put efforts into this, and as far as I know, it's one of the few webinars in the country discussing mental health and linking it to childhood obesity and addressing that issue in primary care.
Okay, thanks, Mary. Thank you to all who are joining. We're going to get started here. I am pleased to introduce Dr. Gary Sigmund, who is the Director of Adolescent and Young Adult Medicine at Loyola University Medical Center. He is also the Medical Director of the Loyola Pediatric Weight Management Program. He will be presenting along with Dr. Denise Steyer, who is the Clinical Director for the Eating Disorders and Self-Injury Programs at Alexian Brothers Behavioral Health Hospital, and she is also in private practice. She will be joining Dr. Sigmund on this presentation. So without further ado, I'm going to turn it over to Dr. Sigmund and Dr. Steyer.
Welcome to all of you. This is Gary Sigmund, and I'll be introducing our module. This is a freestanding module in that we want to introduce important concepts of psychosocial factors, but it doesn't stand alone. Much of what we do is integrated with the rest of the MOC. We have no relevant financial relationships with the manufacturer or any commercial products, and do not intend to discuss the use of any commercial products in treatment of obesity or otherwise. Just to introduce the module content, there's 4 sections. The first section will be the social and family context. The second will be psychological correlates of pediatric obesity. And the third, we'll talk about psychopathology, which is sometimes associated with pediatric obesity. And finally, I'll be introducing some standard psychosocial screening that we think important in caring for these patients and families. In terms of learning objectives, the participants should understand more about the role of parents and adult caregivers, be able to identify and discuss the significance of social stigma in children who are overweight and obese, the effects of obesity on self-esteem and body image. We will be discussing associated mental disorders that sometimes are comorbid with obesity, and we will discuss and hope you can identify appropriate psychosocial screening instruments. And for this next section, I'm going to introduce Denise.
Thanks, Gary. Our first module is the social and family context of the childhood obesity. And what we want to look at, the main components are the role of the family, cultural attitudes and weight bias, reducing weight stigma in the clinical environment. And in doing so, we'll be looking at discussing the weight and BMI and also caregivers' attitudes. What you see here is the ecological model of childhood obesity, and what looking at in this slide are all the different factors that pertain to, impact, affect a child's weight status, and all the different aspects that are important to look at and work with on various levels of modalities and with the treatment teams. As you can see, there's quite a bit that goes into this. The influence of the family. The family is very important in working with pediatric obesity, and they may affect and improve the healthy eating behaviors. There's some areas that emphasize and play impact, such as availability of healthy foods. Not all of our family members our families are able to have access to healthy foods, to fresh fruits and vegetables. How about regular meal times? I know everyone has crazy busy schedules these days, but many families, they don't always have that meal time for them, or even time for breakfast. Everyone's running out the door in the morning. They don't take time to eat and have that first meal of the day. We want to have the family work on model healthy eating. Are they doing so? Do they know what healthy eating is? What are the food socialization practices? And then are we using food as reward or punishment? And then hopefully not. Also, physical activity plays such an important part. Are our communities safe? Do we have opportunities for our children to be able to go outside and play? How often can they do so? How long? And then are we playing with our children, we as in the parents? And this is an enjoyment, fun, and then screen time. The screen time can pertain to TV, iPods, any kind of video game, all the gadgets out there that our children seem to be spending more and more time with. Our parents are agents of change, and we want to work on specific behavioral strategies that are helpful for the obesity treatment, such as goal setting, self-monitoring, stimulus control, non-food related positive reinforcement, and self-management, focusing on specific parenting capabilities that can help benefit their children's health. So what we'd want to look at, some interventions, target behavior, working on having the parents increase physical activity with their children. The stimulus control, not always trying to get that parking spot close to the door, but spending more time walking in the parking lot to encourage movement. Self-monitoring, logging how active the child is playing and exercising. I know they have that slogan right now for 60 minutes a day to play. Reinforcement, acknowledging and celebrating the progress of the child and actually getting out and playing. And then the self-efficacy, developing confidence in the ability to stay active. Once we can get our children active, they tend to want to be more active then. So some beneficial parent-child relationship characteristics. Encouraging the parents to use a warm and affectionate tone, to listen carefully to what their child's saying, to pay attention to the positive behavior, not always focusing on negative, helping their children express feelings in appropriate ways, having that consistent daily schedule so the child knows what to expect, which can be difficult with all the activities or sometimes with our blended homes and where is the child at whose house on what day. We also want to be able to help the parents provide opportunities to make choices, be flexible, provide praise, use constructive conflict resolution. We also want to assess the family health. What is the family's mental health status? Are they struggling with mental health issues that might be impeding or blocking the rest of their parenting abilities? Their physical health. What does marital conflict, how is that marriage? Financial stress that can play a big burden on family situations, as well as substance use or abuse. Is the parent available? Are they working 3-4 jobs trying to make ends meet? Are they around? Can they be around? What are the child care resources? And then also, what is the parent's weight status? That plays a role as well. The social and family context of childhood obesity. We want to focus now on the cultural attitudes and weight bias. Weight and size are recognized and interpreted uniquely in different communities and cultures. It's important to understand the cultural beliefs regarding weight, shape, diet, and physical activity that are unique to your own patient population. Larger body size may actually be preferred by a culture or positively enforced by caretakers. The very thin, waif-like model that we represent in America is not always what many cultures believe is healthy or believe is the ideal, nor do they understand necessarily that their child may be overweight or obese and what that can do to their child. In westernized nations in the United States, the thin body is often associated with such positive traits as power, control, success, intelligence, whereas we tend to look at overweight conditions more negatively. We tend to connect them with lack of willpower, being lazy, lack of nutritional knowledge, poor self-control. This slide indicates the percentage of participants who agreed strongly with negative adjectives in a fat phobia scale. 182 participants were involved. As you can see, the key areas in red: likes food, 80%, overeats, 81%, insecure, 80%. All pretty negative thought processes that go along with someone who might be overweight. Studies show that these biases affect children as young as ages 4 and 5 years old. Erroneous assumptions about body weight, shape, and size constitute weight bias. Weight bias exists in families, communities, schools, and the workplace. Weight and size discrimination is a commonly reported form of discrimination in the United States. Gary's going to discuss more about that now.
Thank you, Denise. I want to bring the issue of weight bias to the place that we work every day, which is our offices. It's well documented in healthcare settings, and it clearly affects the quality of healthcare. A good place to start in our pursuit of improving the care of obese children is looking at our own bias, or our office bias, if it indeed does exist. If you look at nurses by themselves, you'll see that this one study showed that many nurses carried negative attitudes toward obese patients, in being lazy or non-compliant or lacking in self-control, and a very disturbingly high percentage would either prefer not to care for them or not to touch them or felt repulsed by them. This is not limited to our office staff or nurses. Healthcare providers might also carry such biases in that they emerge from the same culture of which we're discussing. So it's very useful to begin to ask yourselves the question, do I ever assume that the obese patient or the families of obese patients are lazy, less intelligent, don't care about their health, or are incapable of making healthy changes? Do I blame the parents? Do I instinctively blame the parents as a default mechanism? And then do my obese patients and parents leave the office feeling more informed about their health, motivated and confident in taking better care of their health, or do they leave our offices deflated, guilty, and in a lower mood? Studies have supported the difficulty with weight bias amongst physicians. Sometimes the attitude affects the number of minutes spent with the patient or the number of medical tests ordered. In general, the amount of respectful communication and patience and positive attitude toward the patient's challenge. The attitudes can strongly influence the quality of health care that the patients receive. So the pediatrician's role in reducing stigma really has to do with adopting a holistic perspective, not only looking at weight, but looking at healthy lifestyle changes, demonstrating respect for patients, parents of all sizes, protecting the child's emotional health whenever possible, and targeting behaviors that are amenable to modification with patient persistent input. It's important to remind oneself that the challenge of weight management is a multifold, complex phenomenon. The overweight conditions are result from many factors, giving the individual child or family less ability to control everything that needs to be controlled. Certainly the genetics and biology are paramount to having some children in the obese state versus others, and they are not changeable. Lifestyle changes that the children would need to make in order for their optimal health are very difficult. We live in a society where the environment challenges all of us, children or adults, in maintaining healthy habits, balancing your energy in versus energy out, And actually the default in our modern culture is to gain weight unless there's some active motivation to create a healthy environment. It's not easy. Parents and families may have tried to manage their child's weight in the past and have had negative outcomes and might bring some of those attitudes toward your office. Finally, studies show that parents may feel easily blamed with certain approaches that professionals take. So we hope that we can all take a recovery culture in our office and clinic or hospital, advocating for non-discriminatory care, avoiding attributes of personal control only for the whole problem, avoid blaming the patient or caregivers, using respectful and non-biased language, providing weight sensitivity and training for staff, developing scripts for thoughtful communication, providing size-appropriate office equipment, and implementing respectful weight procedures. Having spent many years dealing with eating disorder patients and obese patients, I've learned that the weight ritual is very, very important psychologically. It's important to use the weight and the BMI only when necessary. It's not always necessary to do it at every visit, especially if the behaviors haven't yet changed. It is helpful and respectful to ask permission to weigh whenever possible. You don't need to ask if it's something standard, but it should be done respectfully. You should weigh the patient in a private location where the whole unit doesn't see the weight. You should invite the patient to be weighed backwards so that they don't misinterpret any weight change as the bottom line or the final outcome that you're interested in. And you could always discuss the weight in your counseling with them. Nurses or medical assistants should suspend any comments, any smirks on the face, any facial expressions when weighing the teenager. They should record the weight silently without discussion, and they should encourage respectful discussion of the weight and the BMI among the staff. As you will learn in other modules, it's important for the family to be informed about the BMI. You need to make a defining statement as to why you're concerned about that aspect of health. But you need to educate the patients on what the significance is of the BMI and the BMI percentage, and learn tactful ways of proceeding. We've developed an example of some scripts that might be helpful to the listeners regarding the best way to approach this. One needs to ask about behaviors associated with a healthy weight once the caregiver has introduced the area of concern and asked the parent or caregiver's attitudes as well as the young person's attitudes about it. Certain words should not be used, like specifically fat, heavy, or obese, or even overweight. I use statements like carrying a bit too much weight and a body weight range in an unhealthy area. We see here some less constructive and more constructive approaches to engaging families. On the left are some less constructive types of comments, which imply blame, unduly scaring the patient and family, which has shown not to motivate them in a healthy, consistent way, and trying to create complex changes too quickly based on single sentences or language. A better approach would be to start with a defining statement, ask how the patient, how the parent or caregiver and teenager are feeling about that statement. Are they interested in proceeding? Do they have a concern as well, as you've defined it? And then talking about how they've been responding to the challenges that they've recognized so far, how have they found those to be helpful, and what would they like to work on in terms of the areas that they think and you think in your counseling might be useful to changing the situation. So more constructive comments are more holistic. They focus on health. They let they inform the patient and family, but don't dictate to them. There's more opportunity to understand and hear what their attitudes are and their interests in change. On the follow-up visit, the similar construct is necessary. It's better to ask how they're feeling about the changes that we had agreed on or discussed last time, if they have any questions about that, how they're feeling about some of the specifics. Were they successful? Would they like more advice? Have they felt any pressure for the teenager? How are they emotionally handling the stress? Is it causing more conflict with parents, etc.? And how would they like to focus in terms of the next visit? With that, I will reintroduce Denise, who will talk about some psychological correlates of childhood obesity.
Thank you, Gary. To enhance the prevention and intervention efforts of the childhood obesity, there's a strong need for early detection of the psychological factors that contribute to the development and maintenance of obesity. Rather than a stable condition, childhood obesity represents a dynamic process in which behavior, cognition, emotional regulation all interact mutually with each other. The interrelatedness between obesity and psychiatric problems seems to be twofold, in that clinically meaningful psychological distress may foster weight gain, and obesity may lead to psychosocial problems. We are going to watch a video that is courtesy of the Yale Red Center for the Food Policy and Obesity Committee.
Hey, Ralph, what's that, your lunchbox? Ralph. I know.
Hey, Ralph.
Peers are frequent perpetrators of weight bias, with school being the most common setting. Teasing can be in the form of verbal and physical aggression, as well as social exclusion. Many students face this torment daily. It takes a toll on their emotional and physical health and reduces their quality of life. One study even found that the quality of life for obese children is as low as children with cancer.
My friend was picked on by a teacher who he called her like chubby and stuff, and I just thought that was very uncalled for, and a teacher shouldn't say anything like that.
24% of overweight boys and 30% of overweight girls experience prejudice in middle school. That bias doubles in high school, where 58% of adolescent boys and 63% of adolescent girls are the victims of peer teasing.
Oh God, here comes the earthquake.
I've heard my friends talking about a girl who's only slightly heavier than me and like making fun of her. And it makes me wonder what they've said behind my back.
Expressing negative attitudes towards obese people has become one of the last accepted forms of prejudice and can be as hurtful and difficult to counter as racial prejudice.
I see teachers like say something in passing and they don't even realize that it's offensive, and the teachers aren't any better than the students sometimes.
I found a lot of the teachers weren't as sympathetic as I thought that you would imagine a teacher should be, and the support really wasn't there for some of his years, and it really hurt him. It hurt him a lot.
You just feel low, and you just don't know what to do, so you try to comfort yourself with food or games inside all day or stuff like that.
Overweight youth are not only teased at school, but peer harassment can come in the form of verbal teasing, physical bullying, or social rejection from family members too.
You're a disgusting fat pig.
Well, she is turned into a little porker.
Nothing you have fits.
So self-esteem is a big factor with obesity. What we're finding and what we've seen is that many children with obesity oftentimes report low self-esteem. Along with that, overweight children often exhibit greater body dissatisfaction than their normal weight peers. More self-conscious, more self-aware. And then the body dissociation might be associated with lower self-esteem among obese children. Because of the weight bias, children and teens are at a greater risk for teasing, bullying, poor body image, low self-esteem, and poor physical quality of health. And all these factors aren't just from other teens or children. They also get this from adults, teachers, parents. For bullying, which is really in the media these days, a lot of emphasis, a lot of awareness, overweight and obese school-age children are more likely to be victims and perpetrators than their normal weight peers. Tendencies may hinder the short and long-term social, psychosocial development, of overweight and obese youth. It's important to ask about having been bullied or perpetrating bullying for obese children. Sometimes what we'll see is that the child has been bullied so long that then they in turn become a bully themselves. So it becomes a cycle, and a lot of teens and youth get very hurt by this and increase that low self-esteem. Adolescents report of why peers are teased and bullied and the observed frequency. This was out of 1,555 participants, and they stated the #1 reason for teasing was being overweight. What we want the parents and educators to be encouraged is to work on building self-esteem. I think we're so quick to point out flaws and to be negative that tears the children down. We want to work on changing that, building the self-esteem. We want to avoid making negative comments about our own body shape, our own body size, as well as theirs. We also want to intervene if bullying is present. We're part of a bullying coalition here and we're working on intervening and stopping and not just walking away. If we walk away, then we're just allowing the cycle to continue. We also want to work on emphasizing healthy and family lifestyle and social environment rather than focusing on that ideal of thinness. Thinness does not always equate to being healthy. Our third module is psychopathology in childhood obesity. Behavioral and emotional problems are found in many, though not all, obese children and have a higher prevalence in clinical treatment-seeking individuals. The most frequently implicated psychiatric factors are externalizing impulsivity, attention deficit hyperactivity disorder, and internalizing depression, anxiety, behavioral problems, and uncontrolled eating behaviors. Depression, anxiety, and suicidality are very prevalent. Obesity and psychopathology is often related. However, there's no direct correlation either way. Among obese children and teens, there's higher levels of the anxiety and the depression. Obese adolescents are a lot more likely to endorse suicidal ideation and suicide attempts. And as you know, in our area around here, we have a high increase of suicide attempts and completions. 51% of girls who are victims of weight-based teasing had thoughts of suicide, compared to 25% who had not been teased. This is all when compared to average weight peers. Disordered eating. Some children eat when they're not hungry. Overweight children are more likely to eat when they're not hungry than children who are not overweight. 5 to 7-year-old girls identified as eating in the absence of hunger were 4 to 5 times more likely to be overweight than girls scoring low. In 2002, a study was done by Fisher and Birch with children who were overweight or high risk for becoming overweight, and they had scored high as well on this scale. With disordered eating, there's often a lack of restraint or loss of control while eating. Estimates of loss of control are higher among overweight youth, and they also report having greater fat body mass. There's also an increase of secretive eating, either from being picked on, being teased, so they start to eat in secret. They eat when people aren't around. And among our overweight youth, 1/3 of them are engaging in this. Among teens, secretive eating oftentimes predicts development of that eating disorder. And adolescents who report secretive eating have higher levels of depression. Estimates of loss of control range from 4 to 45% among youth. Emotional eating is associated with overweight status among youth, and overweight children often report that they eat when feeling sad, mad, or bored. Emotional eating is defined as eating in the response to a range of negative emotions such as anxiety, depression, anger, and loneliness to cope with negative affect. In overweight children ages 5 to 13 years, 63% said they ate. They ate more because they were feeling the sad, mad, or bored. Binge eating, we've seen an increase with that as well. Binge eating is defined as consuming a large amount of food with an associated sense of loss of control. Children and teens who self-report binge eating predict greater risk of body fat mass 4 years later and into adulthood. Also, children and teens who binge eat have more depression and eating disordered attitudes than matched peers. Gary is going to start talking about the effects of psychotropic medications on childhood obesity. Gary?
Yes, thank you. This has become a very important topic for pediatrics and psychiatry. Many children now have been put in the last 10 years on what we have called neuroleptics or antipsychotic drugs for many indications that go beyond psychosis. Children are also on antidepressants and mood stabilizers, and all three of those classes of drugs might have significant effect on body weight. Children are also often on a polypharmacy approach for complex disorders, making an important goal to collaborate between pediatricians and pediatric psychiatrists and planning preventive efforts when children are placed on these types of drugs. So let's start with the antipsychotic medications. We know, and as all of you do, that they have a higher risk for weight gain in children and adolescents. There's a study by Christoph Carell in 2009 on the childhood population found a dramatic weight gain within 12 weeks of beginning these medicines, and these results are average weight gain. Most of these drugs also show increases in metabolic markers. If you look at the specific types of antipsychotic drugs, you'll recall that the first generation drugs were as seen on your left. The most common ones used today, the second generation neuroleptics or the atypicals, are now being used, and at least in some of the short-term studies, they've shown that least to most in terms of the type of agent that the young person is using. So the aripiprazoles and the ziprazones are less weight-inducing compared to the most olanzapine and clozapine. If you look at the antidepressants, this is less predictable whether a child will gain weight or not. There's different side effects within the same class of medications. Certainly for the SSRIs, some people feel that it's causing them to gain weight and others don't. At least in terms of some of the studies that have been done, it looks like some of the older generation antidepressants, the tricyclics, tend to cause more weight gain than the more modern antidepressants like paroxetine or sertraline, and perhaps more than fluoxetine, which is the most commonly used SSRI in children and adolescents. The mood stabilizers, which were first marketed and tested for epilepsy, are now being used often for mood stabilization and bipolar disease and kids with mood instability, sometimes with ADD, and in autism. It appears that valproic acid and lithium seem to have the most significant effects on weight, followed, as you see, by other agents with the least weight gain induced by topiramate. Now, studies are beginning to emerge that suggest that an intensive prevention program might decrease the harmful effects that are potential for medications, especially the neuroleptics. So one would need to make sure that the psychiatrist who's starting these is carefully choosing the medication, that there be an agreement between the pediatrician and the psychiatrist who should do the baseline cardiovascular risk measurement and routine monitoring, that there should be a full open education about risk, that there should be a preventative plan for food and eating and exercise, and that certain lifestyle changes be discussed along with the prescription of those medications, as well as certain CBT strategies. Certainly, pediatricians need to review all the medications that the patient is on in their own office and try to communicate with the psychiatrist to see who will test and monitor the risk factors. I'd now like to begin our concluding section, where we talk about the practical aspects of screening for psychosocial parameters in a way that we think is doable and encouraged for pediatric practice. It must be clear by now from our comments that successful treatment of overweight children and teenagers is more than just an energy in and energy out phenomenon. It's important, therefore, to screen for things which might be necessary to address as we try to help these young people. So these are the important parameters that we want to make sure we understand if they're affecting our children: depression, anxiety, whether there's eating disordered pathology, whether they have been victimized or are children of abuse. Now, we're not creating a new idea. As you see from the AAP Bright Future Schedule for Health Supervision, that psychosocial and behavioral assessment is certainly blacked out, which means it's indicated in every age checkup for children and teenagers. A very commonly used instrument to do this is the PSC, or the Pediatric Symptom Checklist. There are 17 items for children. Many offices during specific visits have their office personnel give these checklists to the parent, and the doctors have learned how to efficiently score these items and then make a comment whether the screen has resulted in the need for referral or further treatment in one's office. For children 11 to 16, the YPSC has been developed, and it has more items. It's a 35-item checklist which goes right to the teenager. The instruments that we're suggesting to you can be found at the references that we are putting on your presentation. When you see the PSC, you see that it helps the pediatrician conclude about some aspects of mental health in relationship to 4 domains: internalizing problems, those being depression and anxiety; attention problems; externalizing problems as defined by conduct disorder or oppositional defiant disorder; and suicidality. It's important to recognize that every instrument that we introduce today are only screening instruments. They are not meant to confirm diagnoses. They're meant to allow you to be aware of what would be the next step in further diagnosis yourself or to refer. As you'll see on the website that we have given you, a PSC score of 15 or higher suggests the approach of significant behavior or emotional problems. And depending on your office style, you could either continue to work those up in your office by your staff, yourself, or if you have a co-located mental health professional or social worker, or you need to refer out for such further evaluation. And as I mentioned, there's 3 subscales which help you understand more specifically what needs to be done. Now, we also want to address efficient screening for disordered eating, victimization, and family-related problems. For all the eating concerns that we have discussed, I have suggested that you ask these 5 questions. Do you ever eat just because you're feeling sad, angry, bored, or lonely? That question is a screen for emotional eating. Do you ever eat in secret or hide the fact that you have eaten some food? That is a screen for some shame involved or fear of recriminations from family or caregivers. Does the way you eat affect the way you feel about yourself? You're getting more towards self-esteem issues. Do you feel that the way you eat is out of control? You're looking for either binge eating or out of control eating. And do you ever make yourself vomit in order to control your eating? This is not unheard of in children. Most children might just eat out of control and then feel bad or guilty about it without some compensatory behavior after. For those of you who are interested, this is not suggested as a formal standard for every office, but I have found that certain other instruments that are in the public domain help you go further in understanding your children's eating disorder behavior if they demonstrate such. There's an eating attitudes test, which was created for children, called the CHEAT. And then for older adolescents and adults, there's a 26-item EAT, or eating attitudes test. Those are downloadable at the website written below. For stigmatization and victimization, we're not asking you to use any formal instruments, but to ask 2 simple questions. Do you feel other students pick on you more frequently than they pick on other students? And do you think others treat you differently because of your weight? An overwhelmingly positive number of children who are obese will respond positively to this, and it's important that they felt understood and heard. And depending on the severity of their concern with this, the pediatrician should make a determination whether they need some other aspect of treatment beyond just weight management in your office. For family problems, the Academy has already developed a very good instrument called the key questions regarding potential significant family difficulties which you might need to know about in your pursuit of helping this family. Sometimes, as you'll see, some weight management might be a necessary lower motivation if the family is struggling to survive or has other major problems. So just to review the summary of the psychosocial screening instruments that we've suggested, the PSC and the YPSC for general mental health screening, the CHEAT or the EAT for further understanding of the eating disorder behavior or attitudes, 2 questions for victimization, the PSQ for family functioning and risk factors, and further diagnosis and management of any suspected comorbid features unique to how you run your office practice. Certainly anyone who wants to learn much more about mental health concerns in primary care should explore the clinician's toolkit that the Task Force for Mental Health of the AAP created a few years ago. So let us summarize the key points. And to do that, I'd like to ask Denise to just finish us out.
Thank you. All right, so today we learned that it is necessary to understand the psychosocial context of childhood obesity in order to understand the etiology and treatment, including stigmatization, cultural differences, and family factors. We also learned that childhood obesity is associated with problems in self-esteem, victimization, and quality of life. Depression, anxiety, and disordered eating can be related to the cause or exacerbation of obesity, and the provider should screen for mental disorders and family mental health in order to effectively treat obesity. We also have here our Gary's and my bios, and we thank everybody for their participation and for working with us as we worked out a few kinks that we had here along the way. Sarah, did we have time to ask for questions?
We do. We have a few minutes before the top of the hour, so while we have our experts on the call with us right now, I'd like to ask anybody if they have any questions. You can either type them into the chat function at the bottom of your little panel, or you can raise your hand and I can unmute you and you can ask the question that way. All right, so we have a question from Mary.
Dr. Sigmund, can you tell us whether physicians would be able to get any additional reimbursement for any of these mental health screening tools in our Illinois Medicaid program?
Yes, I have personal experience with that, and I'm pleased to say the answer is yes. At least the state, Medicaid, the developmental and behavior screenings use the same code, and they are readily reimbursed for our Medicaid population. So just like the pediatrician is bound to do autism screening and other developmental screening, the very same codes are used and collectible for the PSC screening. The private insurers, Blue Cross Blue Shield and others, don't always readily pay for that. And so when doing those screens on families of those private insurers, one needs to make the statement that although you feel it's important, there might be a charge, and every office has to decide if they want to waive that charge or charge for the private insurers.
Great, thank you. Do we have any other questions at this time? Great. Well, if we don't have any more questions, this concludes our webinar. I want to thank our experts for presenting today, Dr. Sigmund and Dr. Steyer. Thank you very much for providing us with your presence today. It's greatly appreciated. And thank you all for attending. This will be offered as enduring material on the LMS. And we will have copies of the screens that Dr. Sigmund mentioned in this presentation on the LMS as well, either in downloadable forms, or if we can't get you a downloadable form, there will be a way for you to access them via the internet. So hope you have a great weekend, and we will talk with you soon.